my name is Xavier Leleu. I'm professor of hematology specialist on multiple myeloma in a city called Poitiers in France, Academic Hospital of Poitiers. On behalf of the IFM, Intergroupe Francophone du Myélome Multiple, I'm very happy that we have presented at ASCO 2024 the abstract with the title Isatuximab plus lenalidomide and dexamethasone with weekly bortezomib versus Isatuximab plus lenalidomide and dexamethasone in newly diagnosed multiple myeloma, transplant ineligible, a study called BENEFIT or IFM 2020-05. At the background, I want to remind everyone that there is a study for registration, phase 3, sponsored Sanofi pharma company called IMROS, that has looked at the possibility to give a quadruplet-based regimen in patient transplant ineligible against a standard of care, bortezomib, lenalidomide, dexamethasone, bortezomib giving twice weekly, and the quadruplet being VRD plus Isatuximab, an immunotherapy CD38 targeting. Now, in many countries in the world, including France, there is another standard of care based on MAIA, daratumumab, lenalidomide, dexamethasone, DRD, which has been using instead of bortezomib, the first-in-class immunotherapy targeting CD38, daratumumab. We also know that with the experience on using bortezomib, particularly in transplant ineligible patients, over the years, we have used a bortezomib weekly regimen, which has appeared to be almost as good as a twice weekly, but much better in terms of safety profile, particularly neurotoxicity. We also know that it is important in that population to stop dexamethasone early on. And we have been very happy to hear that the ODAC gave an approval for the potential use of MD test and negativity 10 to minus 5 rate in April 2024 as a primary endpoint for studies in myeloma. So we have conducted a phase 3 randomized 1-to-1 to look at the added value of weekly bortezomib to the standard of care Isatuximab plus lenalidomide and dexamethasone being a MAIA-like regimen. And we report the results of the primary endpoint of the analysis of BENEFIT, the first academic French phase 3 study in investigating efficacy and safety of IsaVRD versus IsaRevDex in patient transplant ineligible and newly diagnosed multiple myeloma. So the key highlights of the ASCO presentation were that BENEFIT is the first academic study to look at the quadruplet versus the historical triplet MAIA-like Isatuximab lendex. It is also the first phase 3 to use MD as a primary endpoint. In this presentation, we have shown that there was a statistically significant improvement of MD negativity rate at 12 and 18 months, at 10 to minus 5 and 10 to minus 6 overall and in patient in complete response. And the safety profile was not very different than the one we initially expected when you add bortezomib weekly to a standard of care regimen. And it was also the first time ever that we presented data on Isatuximab, lenalidomide, dexamethasone, this triplet-based regimen, and how close it was from the MAIA Dara-Lendex historical one. So the slide I'm showing now is a study design, randomized 1-to-1, 270 patients recruited, 135 per arm. The two-arm IsaLendex was as expected. The main difference was the bortezomib. Bortezomib was given sub-Q, 1.3 milligram per meter square, given 1/8-15 for the 12 first cycles, then 1/15 for the remaining 6 cycles. Bortezomib was permanently interrupted at month 18, cycle 18, which was the timeline, the date of the primary endpoint, MD negativity 10 to minus 5 by NGS, and if NGS was failing by CMF. Now, the MD was also looked in the marrow at 12 months and 24 months and yearly. Patient disposition. So I've said that 135 patients recruited in either arm, 25 in bortezomib-lendex and 33 in IsaLendex did stop the treatment, mainly for progressive disease. And so the remaining patients are ongoing. The baseline characteristics were not very different from what we would expect in a study recruiting 65 to 79 years old, median age around 73 years old. Approximately 36% of the patients were equal or above 75. Approximately 21 patients were below 60 ml/min of clearance creatinine. 10 to 20% of the patients had some degree of high-risk features, depending on definition. So the primary endpoint is the study of the MD negativity rate at 10 to -5 at 18 months. And so at 18 months, 53% of the patients were negative for 10 to -5 in the quadruplet bortezomib-lendex arm, compared to 26 in the triplet Isatuximab-lendex arm, odds ratio 3.16, highly statistically significant. Interestingly, this difference, approximately, by the way, in the same range, was also observed at 12 months and was also observed, most importantly, at 10 to -6. So at 10 to -6, for example, at 18 months, 36% of the patients were MD negative and 17% were MD negative across bortezomib-lendex and IsaLendex arms, respectively. Odds ratio 2.74, again, highly statistically significant. When we looked at the population that was MD negative in complete response precisely at 18 months, we found approximately the same results, though in a lesser extent, but the difference went in the same line. When we looked at MD subgroup, pre-specified, analyzed according to certain characteristics, for example, age at the cut of 75, we found out that the benefit of the bortezomib in improving the MD negativity rate at 12, 18 months, 10 to -5, 10 to -6 overall, and in CR patients was demonstrated in the same extent above 75 or below 75. Same for patients in high risk, and the same for patients with renal, some degree of renal insufficiency versus patients that had no renal insufficiency. Not surprisingly, when we looked at the response rate globally, the overall response rate, the partial response rate, the VGPR and better, CR and better, was systematically better when we added bortezomib to the IsaLendex regimen. For example, at 18 months, the complete response rate to better was 58% versus 31%, odds ratio 2.97, highly statistically significant. We also found out that the time to occurrence of PR and VGPR was shorter when adding bortezomib. The survival is immature. All I can say about the survival is that the 24 months median, so 24 months PFS, sorry, estimated 24 months PFS was around 80% in both arms, and the estimated 24 months overall survival was around 90% in both arms. The exposure to study treatment, the relative dose intensity of isatuximab, lenalidomide, dexamethasone was no surprise, as expected and similar to, for example, the DARA, lenalidomide, dexamethasone reported in MAIA. We had, of course, a specific look at the bortezomib, which was the fourth drug added to the IsaLendex regimen in the studied arm, and we found that 91.6% of the patients were treated per protocol, according to protocol, which was very reassuring on the ability of the investigators and the patients to give the bortezomib as initially planned. So the weekly regimen appeared really feasible and manageable for these patients. When we looked at the reason and the incidence rate of patients who had to discontinue definitively the treatment, we found that it was very limited for isatuximab. And then for lenalidomide, dexamethasone, and bortezomib, it was approximately 10% across arms, with no difference much across arms, showing that the addition of bortezomib to the triplet isatuximab, lenalidomide, dexamethasone arm didn't bring any extra safety profile issues. When we looked in more details into the safety population safety summary, we found out that we observed more thrombocytopenia and more severe thrombocytopenia in the bortezomib arm versus no bortezomib arm. And we also observed more symptoms traducing that there was an increased peripheral neuropathy issue in looking at the peripheral neuropathy report, but also, for example, the peripheral edema report, but no severe, very limited severe experience of these events. So in conclusion, benefit is the first academic phase 3 study of an anti-CD38 monoclonal antibody isatuximab in combination with bortezomib and dex in patients transplant-eligible newly diagnosed multiple myeloma, 65, 79 years old. We demonstrated that the addition of bortezomib resulted in deeper response rate, deeper MRD negativity rate at 10 to minus 5, at 10 to minus 6, as early as 12 months, but also at the primary endpoint of the study, 18 months, and in the overall MRD population and the MRD population in complete response. Isatuximab, bortezomib, and dex was well tolerated. Isatuximab, lenalidomide, dexamethasone, the triplet arm, the control arm, performed as expected, particularly looking at the MRD negativity rate compared to anti-CD38, Rev-dex, other regimens, and not to mention Daralendex. So the two final conclusions, this study provides evidence that weekly bortezomib regimen in the context of the quadruplet ISA bortezomib lendex regimen can be effective, a feasible option for newly diagnosed transplantable patients. And the last conclusion is that we demonstrated an improved efficacy of quadruplet versus triplet, IsaVRd versus IsaRevdex, and the safety profile, which is manageable, that provide an important treatment option for frontline disease control. And so we believe that the quadruplet-based regimen, isatuximab, bortezomib, lenalidomide, dexamethasone, with benefit bortezomib weekly and IMROZ alongside benefit twice weekly, demonstrate that this quadruplet, isatuximab, bortezomib, lenalidomide, dexamethasone, is a new standard of care and maybe the new standard of care for the population of patients transplant-eligible newly diagnosed myeloma, as it's shown for the two studies, very strong and very impressive data compared to the historical standard of care, VRd and Dara-Revdex. And at the day of the 3rd of June, on the day of the presentation at ASCO, I was very happy to share that the paper was now published in Nature Medicine. And I would like to thank indeed many people who participated to that academic study, indeed the patient and the caregivers, but also the IFM team, my institution, the CHU Poitiers team, Sanofi for the funding and the providing the isatuximab, and indeed acknowledging all the centers, investigators, the CRC, all the research team in all the centers, and last but not least, sorry, the Nature Medicine editors are trusted in us, and I would thank you very much for your attention as well.